Thank you for the introduction, but I'm really embarrassed by all of that. But the main thing is that looking around the room today, I sort of know most of the families because we've seen them in the clinic and helped manage some aspects of the. Thank you. Some aspects of their problem. So what I'm going to do is try and discuss what the center does and how we came about it, and I'll try and first of all, the conflicts of interest, as I lead both the centers, the CIPP as well as the CIPP Rett Centre. We developed the Health Tracker Limited. It was a health tracker platform which we developed when I was actually at Guy's and St. Thomas's, in fact, in the Newcomen Centre and the Maudsley in 2003. And since then, the platform's been used in multiple different settings, and we use it for the Rett syndrome monitoring. So what the center does, the CIPP is that we've got two main streams. So we've got the rare disease stream and we've got the complex neurodisability stream, and of course a lot of the research which we've done. So in terms of the rare diseases, we've got the CIPP Rett Centre, where we've got currently over 200 patients who are being followed up and monitored. We've got large cohorts of children with septoptic dysplasia, with Phelan-McDermid, and we've got all of the mucopolysaccharidosis. So we've got more than 60 to 70% of our whole caseload is rare diseases, and we also provide the service for Tadworth Children's Trust, which is an acquired brain injury service. So we have those patients, but the other aspect of it is to do with the complex neurodisability here. These are multi-comorbid, so most of them have, it's almost a given that every patient who comes with a non-rare disease have ASD, ADHD, and oppositional defiant disorder, plus they're psychotic or catatonic or something like that. So they have more rare disease presentations as such. And whenever there's a serious side effect of psychotropics, wherever it is in the country, we end up being referred those patients. So patients with neuroleptic malignant syndrome, patients who end up with long QT as a consequence of medication, they come to us. So one of the things that we recognized early on is when there's treatment resistance, it looks like there's autonomic dysregulation irrespective of what the diagnosis is. So we decided to focus our research on autonomic dysregulation, and that has continued to be part of what we've done. So in terms of the links between how the center sits, clinically it sits in Maudsley Hospital, and in terms of the academic thing, we've got links with King's plus many other organizations depending on what research project it is. So far we've been using the King's College Hospital Clinical Trials Facility, and we've linked up with various departments. And more recently, we've formally developed some links with Great Ormond Street with respect to neurosurgery and neurology to be trying to provide transformative therapies. And of course, we've had support from Reverse Rett right through from its inception, and Health Tracker has been part of the generation of data. So one of the things that we recognized early on, not just because of Rett syndrome, but because of managing emotional and behavioral symptoms in children with rare diseases, is that we really had to understand whether there were any problems which were present before the diagnosis itself. And so if this is just simply in terms of this is a gestational thing, this is at birth, and then after that what happens with respect to various aspects, whether it's to do with myelination or other things. And what is very clear for us is that in our population at least, this is a skewed population, don't get me wrong, this is not the typical representation, but in the skewed population, there's a clear association between problems that occur pre-diagnosis and outcomes as such. So rather than looking at it just as a single mutation problems, that seems to be an issue. So this is, I've just nicked it from previous presentations, but the thing is that you can see in Rett syndrome what happens is that you have normal developmental here, then you have stagnation, and then you have autistic features appearing, respiratory, autonomic, cognitive, anxiety, seizures, Parkinsonian features. So what we deal with very specifically is to do with managing whatever is needed here, managing autonomic function, anxiety, and respiratory because of to do with the hyperventilation or breath holding at the very, very basic level. And now increasingly what's happening is that when it comes to dealing with Parkinsonian features, we end up being asked to, because there's a long waiting list when specialists are not available, and therefore then we are linking up with the GPs and the local pediatricians to see whether we can come up with a pathway to manage that. So this is before we set up the CIPP Rett Centre. This is the pathway which was there for how you accessed care in Rett syndrome. So you had the parent or the carer and the GP, but it was basically the parent who was taking the full responsibility of managing all this huge layer of thing. On this side, you had all the things to do with the various sort of non-biological therapies, the OT, speech and language, and so on and so forth. And on this side, you had to deal with neurology, gastro, surgical teams, orthopedics, all of those things which go on. So what happened was that there's no central care coordination being provided for a condition like this. This is multi-systemic, and the poor parents had to keep sort of going from pillar to post, trying to understand how to manage these things. And one of the things we picked up very quickly was that the parents were then having to, they were not able to filter what information should be given to which specialist. So they were actually going around talking about everything that happened between two visits. So they'd go to the neurologist and then talk about everything, including gastro, including thing, and so on and so forth. So what we ended up doing is that we started, as part of our core mission, was to start assisting in repackaging medical information. So that this is the kind of information you actually talk primarily to the neurologist. This you add to it. This you talk to the cardiologist or to the gastroenterologist. So it allowed the parents to suddenly feel enabled to be able to give the right information and the valence to the information to the right professional. So suddenly it actually enabled them to be able to get better outcomes from the clinical contact with the specialists. So I would suggest that this is one of the big issues that we had before. We established in 2019, and so this is what it does now. So anyone can be referred into the CIPP Rett Centre. It can be a GP, it can be a consultant, any consultant, it can be self-referral. Once they come in, they can get, the parents complete some questionnaires. We get information which is there. We then are able to triage automatically using AI algorithms, so which triggers and tells us this person's symptoms appear to be outliers. Do you need to do something about it? So we can actually prioritize who should be seen first and manage them. And so, and there is no age limit to patients being seen in the center. So it's a lifelong service. And here, what happens is that the most important thing to remember is that we are not taking over the care of the patients. It's a shared care. We continue working with all of the local providers, and so that we try and improve the links with them. And we are not claiming to have the expertise in all areas. We only have expertise in the areas that we believe we do. So the kind of thing when we are looking at complex multimorbidity, we previously used to just simply talk about biopsychosocial approaches, but now we've also included ecological approach, which is basically to do with I'll just focus on this, which is to do with what is the disability, what is the impairment, what are the barriers to access of services, which is a huge issue when it comes to rare diseases. Unless you understand what is the barrier to accessing the right care in your locality, you're unable to actually fix that or even to deal with it. So we spend a lot of our time in the clinic to be able to actually understand what the barriers are and then come up with personalized solutions for that. And also, especially when it comes to working with health, education, and social care. And of course, the mental and physical health collaboration, which is a huge problem because suddenly mental health has started coming in, but the physical health is very different and divorced from it. And so we work with the teams to be able to get that. So what we set up from the beginning was that we knew, as Dr. Shetty and everyone has been saying, if we don't have data, we're not going to be able to get the best out of it. So we developed what we call the data warehouse for the center. So what happens is that anyone who comes into the clinic, we have physiological monitoring automatically happening. That we use variables to get the data. We get pharmacogenomics done, so the data for pharmacogenomics gets into the data warehouse. We have, this is a scale which I'll talk about, the multi-system profile of symptom scale, which is one of the only scales that have been developed in Rett syndrome, which has followed the FDA protocol for development, and it's been now being reviewed by the FDA. And what we also got is the issues to do with the response. What symptoms change when you intervene with any intervention? And so we've got what is the impact of of symptoms on parents, and also very specifically about breathing difficulties and how it impacts other symptoms. So all of this information goes into the health tracker, into the database, and on every 6 monthly we generate analytics, and then we can develop AI methodology to be able to understand what happens, and then hopefully provide more precise, individualized treatments that are possible. So the kind of information that goes into the data warehouse is medical information from the records, pharmacogenomics, we are trying to get immunophenotyping and sequencing as such, and all the lab tests and vital thing as such, and we use the machine learning algorithms. And we are now streamlining all the referrals accordingly, so there's very little delay as to who needs to be seen first. So these are the kind of symptoms that we end up taking information about. And so, for example, issues around the genetic abnormality, communication issues, epilepsy, spasticity, dystonia. So this is where most of the time it's neurology providing the support for this. And when it comes to what we provide support for the emotional dysregulation, the behavioral dysregulation, and the autonomic dysregulation, because currently there are very few centers that deal with anything to do with autonomic function and in terms of interventions. And we also, at the same time, profile the pain, constipation, all of those things, so that we can then use that information to contact the local team to be able to try and develop a pathway for them. And of course, a lot of it is to do with medication side effects. When multiple professionals have been prescribing, you can see how they have not there's very little crosstalk. So one of the medication for, let's say, a proton pump inhibitor started, and then there's no crosstalk between the other teams, and so there may be problems with respect to how side effects occur. In the health tracker, based on information that goes in, we've got an algorithm that then classifies response of medication according to what it is in terms of, it's actually a 4x4 grid, which is all of this is in the red, means that the risk outweighs the benefit. When it's in the amber or yellow, basically this is when you have to actually try and change dosages to see whether you can get more optimal outcomes. And when you're in the green, you know that the benefit outweighs the risk as such. And so this is an individualized thing which comes out at the end once the whole profile is done. You get this from the thing, which then means that when you are making decisions about patients, you can actually look at this and then decide, hang on, there's no point in me trying clobazam again after 2 years, or chloral hydrate, because there was something that happened and they ended up with a cardiorespiratory arrest or something like that. So therefore, we can actually see it on a single screen. So this is the questionnaire which we developed called the MPSS, and it's got subscales. It's got 12 subscales which are till sensory problems. These are all validated, and each of these subscales were independently validated, so that you can actually just use one subscale because it's completely validated, FDA protocol driven validation, and we've published it previously, and in fact it's one of the scales that have been included into the Rett syndrome monitoring package which is being considered now in the FDA. And these are the sort of subscales which are not 1 monthly thing. This is for 6 months because you need information about skeletal changes and so on, which takes longer. So we generated it using from literature review, you typically developing focus groups, item definition, then rerunning it by focus groups, going through the web-based logic definition, then setting it up and testing it out with parents, and then finally validating the whole thing. And so the way it's set up is that you can start with a question would be there about mental health. I haven't really put it in here in terms of the exact question. It comes up, it describes what mental health issues are. Do you think that your child has got any of these issues? And if they say yes, then you get the whole, that module opens up. And if it's a no, then you skip it, and then it goes on to the next. So it's like this. So for example, it might be, and each of these are on the screen. You can actually expand it, and you'll get all the information that is needed, and you get the scoring automatically. And once the module is done, automatically the questionnaire gets scored. It's stored in the backend and the database, and you can export it at any time and look at it longitudinally. So this is, for example, based on 90 patients something like 90 patients in our clinic, and it tells you what is the level of problems being reported in our service, the ones who have come to us. And you can see motor problems or the thing issues. And you can see that when it comes to neurovascular, there are some issues here, and so on and so forth. But the cardiac symptoms are reportedly low, but when they are present, it produces quite significant impairment because almost every medication started leads to long QT, and then we have to constantly be working with the cardiologist. And we are now working with the cardiologist to see whether we can develop a protocol how to manage medication-induced long QT as opposed to, so they're just vulnerable to long QT, they don't have a long QT syndrome. But because of Rett syndrome, and I think it's to do with the fact that you've got a brainstem in the cardiovascular, the respiratory center is not as mature, we end up having more problems with them. And the health tracker was used during COVID, where we got families to complete questionnaires on a weekly basis. And what you can see is that we were looking for fever and breathlessness, and that actually led to the pattern being exactly as the peak of the various phases in COVID. And this was just based on the 2 items which the families completed on a weekly basis. And we recognized that breathlessness had to have a separate cutoff because we already had breathlessness as part of the Rett syndrome. And so the AI algorithm then provided that, and that helped us to manage to contact families and keep them out of hospital. So in terms of EBAD, basically, you've got behavioral dysregulation with all sorts of things which are obvious here. Emotional dysregulation, which you've got symptoms here. And of course, the autonomic, where you've got from breathing to temperature changes and so on. And what happens is that when you have physical problems, like let's say you get sepsis or you get an infection, that interferes with how the EBAD gets exacerbated. Puberty, when it kicks in because of hormonal changes and other things that kick in, that actually makes it more unstable. And of course, when there are increased stress as such. And so what we then looked at is profiling patients in terms of EBAD and looking at their physiological data to see whether we can come up with subgroups as such. And we developed an EBAD questionnaire, which again has been validated, which is very quick to do, which then allows us to capture what's happening during that time. So this is to do with just when we started off, how these were the existing algorithms in terms of using just sleep-wake algorithms, which allows us to know when patients were awake and when they fell asleep and so on, and so that we could then classify the autonomic variables during a wakeful state and when they were asleep. So this is now what has happened is that we've got to the point where we've developed our own AI-generated algorithms, which can then characterize what happens during. So this is to do with the movement from the 3-dimensional X, Y, and Z axis in terms of the gyroscope. and then this is to do with just the z-axis, and this is the electrodermal activity. This is electrodermal activity, and anything above this black line is we've set it as 5 microsiemens, which is what is used by the FDA for deciding whether there is something that is abnormal or not. And you can see in this particular individual, when the person was going to sleep, there were sudden changes in electrodermal activity, which was not present during the day. And this is to do with heart rate, and again, this is 100 beats per minute. And this is during sleep, and this is during the waking hours. And this is surface temperature as such. So now what has happened is we've now further developed the algorithms. So now we can actually look at the group data. Once the data, all of the recordings which are there, on a click of a button, we can actually rerun the analysis using new algorithms, which we now have the norms of what would be expected as norms during the day, during the night. And so we can actually automatically get the whole algorithm based recordings and numbers. So all of this tells you what the electrodermal activity, the data is, and activity levels and so on. And all of this then automatically goes into the data warehouse. So we don't have to manually do everything because we've generated the AI-driven thing. And then what we've done is we've actually developed, for the first time, we actually got what we expect to happen when it's Rett syndrome in terms of heart rate variability, which has been published. We've got quite a few areas that we worked in terms of autonomic dysregulation, in terms of what autonomic characteristics occur in sudden death when it comes to other conditions, and what should we learn from that. And movement disorder, similarly from other things, what should we learn from that using systematic review approaches. And this, I think, was one of the first times that we actually used AI to separate out those individuals who had ASD versus those who just had Rett syndrome. And that was based on AI algorithms. It was the first time that was done, where using the variables, it was a 97% separation out for using the algorithm. So now what we've done is, this is just, it's not yet published, this is just something that we analyzed just this week. This is based on 58 patients' data, where we looked at the data at night collected on the watch data. So this is accelerometer, this is blood volume pressure, this is electrodermal activity, and this peripheral temperature. And what we did is, using AI, we actually clustered the data. And what we found is 3 different clusters. And what is very clear is that cluster 1 is a sympathetic overdrive, this blue thing as such. And what you can see here is, with the blood volume pressure, there is very little variability. It's very stiff. There is no ability to move and adjust to needs. While in the red, you can see that the electrodermal activity is very low and normal, but at the same time, you can see there's a lot of variability here. So again, because we are using the MPSS, so what we did is, we looked at what is the impact of breathing difficulties on other symptoms. And this is directly asking, when you have breathing difficulties, when you're having, in terms of hyperventilation or irregular breathing, how does that affect things like chewing, dystonia, stamina levels, seizures, and so on and so forth. And what you can see is that this, and especially this purple color thing, is where it has a severe impact according to the families. As you go towards this end, it is the white on this end says that there is no impact of breathing difficulties. So what we can use data like this is to start quantifying and converting it into economic models to say, if you've got breathing difficulties, you know what other symptoms those kind of breathing difficulties will have an impact on. So you can then start developing algorithms to start calculating cost as to how things would be if that kind of profile. So if you manage to improve breathing, you're not just improving breathing, but you're also able to say that because the breathing being improved, you have got a cost impact to other symptoms as such. So, and this is, again, it's not yet published. This is based on data on 30 patients with busprone, and you can see, and we're systematically being looked at in terms of EBAD, and it clearly shows that with busprone, EBAD symptoms seem to improve quite significantly because it's anxiety-based and autonomic-based as such. This is just to say that there are different systematic reviews that we've conducted. And again, in terms of autonomic dysregulation, this is from acquired brain injury. What can we learn from that? Again, in terms of sudden death. And so here, with when we looked at all of the data on sudden death as such, what seemed to be important for us to work on, which is why we are working with cardiologists, is that in individuals in a specific, because there is a brainstem vulnerability, most of the time there's nothing that, everything is safe. You can have a seizure, nothing happens about it. But if you've got someone who's got significant sympathetic imbalance as such, autonomic dysregulation, one of the things to remember is that when there's breath holding, your QT increases. So if supposing someone has got a propensity to long QT and they have breath holding at the same time and they have a seizure which then spreads to the brainstem, and they have long QT because of some medicine being done or being used, and they're on high doses benzodiazepines, which means that for managing tone, whatever, then the sudden automatic the respiratory shift becomes more difficult for that subpopulation. So what we've done is we've started looking for risk in the clinic population to identify that small subgroup. So it's not for everyone, a small subgroup of individuals where they may need cardioprotection, which is where we've ended up introducing beta blockers after having discussed with cardiologists to see whether we can produce some cardioprotection. Then the other thing that we've done is the pharmacogenomics, because we started getting pharmacogenomics from everyone. So that allows us to look at the prediction of who may be a slow metabolizer or a fast metabolizer for the purposes of certain groups of drugs. So for example, just last week we had a patient who was not responding to antiepileptics and was on brivaracetam, but actually they had a very specific mutation which actually meant that they were a slow metabolizer, they were a fast metabolizer, and so the prediction was not to use thing unless you ended up using it more frequently. So what we did was we actually copied the section on AEDs, contacted the consultant, and sent the information over for them to make the decision whether they needed to do something about it or not. So that sort of thing is something that we are doing, not because we can do anything about it, but the information is useful for the right professional to make decisions. And it may be that you don't do anything about it, but it's just providing the information to those people. And then again, this is a thing about movement disorders, which is just to discuss how we ended up doing that. And the last one was to do with gene therapy, where again we published this just to do with a summary of what existing information was there at that time when we published, which is in May 23. And this last part of it is to do with, I was very interested in what Dr. Shetty was talking about, the video-based epilepsy thing. We've already done that, and I had no clue that it was something that was even being considered elsewhere. And so as part of that, what we've done is we've developed a digital clinical passport where we have, in terms of risk issues, symptoms, and drug-drug interactions, these are in the sort of aspects where it is the written part of it. But then what we've got is the video, where we've developed it as a digital passport. So what happens is that you've got here, this is the time. So the video, once it starts, I've got a dummy video to just show what happens. But what happens is that you have you can classify here at this particular time. It tells you exactly the time when the events that you're seeing, you may classify it as, we think it's EBAD, or it could be seizure, or it could be dystonia. And so the whole digital passport may be around 50 minutes, but we synthesize the whole thing into a 5 to 6 minute video clip, which then becomes what is given to the family to take with them so that they can actually describe it to anyone and train families as needed. So here on this side, you have the diagnosis, and here's the time in terms of the variable to be able to identify what's the link between the variable and how it is, and so on. And so this is, so this is just to show you, this is a dummy, so it doesn't show you everything because I didn't want to use a patient thing, but what I just wanted to show is how you have the thing, we put the variable on, and then after that you have the timing which comes in, and it tells you at what time, and as something is being is happening, then it light up. So if there was a seizure, it would be a seizure with confusion or whatever it is. This is not, I don't want you to think that this was a seizure, but it was just a mimicking to show how it can actually be used. And so we've developed this whole strategy so that it could be, we've got around 12 different things that can be classified, and you can actually know the exact timing for it. And it can be linked up to whether if it's an EEG or it is a variable as such. Now, this is not an easy task because it is, when I presented this as a personalized medicine approach to being able to help improve care, I was told off to say that this is not personalized medicine, this is personal medicine, because this video is only for that patient and it's very specific to that patient. And so this was personal medicine at its core, and I agreed that that was fine. But what I wanted to really highlight is that these passports take roughly a whole day of intense work from one person, and we only have 2 days of the specialist. But when he does it, so hopefully with time we'll be able to get through the 200 plus patients, but we've done around 20-25 patients, and those will then be handed over to the family to be able to use when they're in crisis. And what we are planning is to look at an effectiveness trial where half of the families would be given a video to use when they go into a crisis, and the other half wouldn't, and then we would be looking at all of the outcomes to see whether it actually will make a difference or not. So, sorry. And this is just feedback from parents. The parents seem to appreciate what's being done. And we're very, very grateful for all of the support being provided by everyone as such for what we're doing. So I would suggest that when I summarize it, I would say that the strengths are that we have a quick response time, we focus on very specific things of EBAD and challenging behavior and so on, and we provide with the physiology as well as the pharmacogenomics. And our main task is highlighting aspects of what needs to be highlighted to other professionals. It's a multi-specialty liaison, improving general management, psychological support, especially when it comes to very difficult scenarios that families are having to do. We've recently developed the automated alert to the psychologist based on the burden questionnaire from the parent, so that it triggers an automatic thing to the psychologist, so the psychologist can immediately contact the family proactively to do something about it. And in terms of liaison and so on and so forth. And I think, and of course, because we've got lots of different questionnaires, we are collecting data longitudinally about symptoms, quality of life, health economics, and so on at regular intervals. And so this is the last slide, just to say that I then look to see how can one actually evaluate whether something that you're doing clinically can be thing. And so this is a published standard in the Lancet in terms of how to evaluate whether something which is to do with patient care. And they talk about it as being timeliness, equity, patient-centeredness, efficiency, effectiveness, and improving safety or reducing risk. These are the criteria by which currently they're evaluating services. So what I just simply did was looked at timeliness. We do have a very quick response, so we can actually manage that. In terms of equity, this is making sure that no one misses out. We are trying different strategies to see whether we can get, especially people with from ethnic minorities, whether they're actually accessing the service. That's something that we are actively trying to do. And of course, when it comes to digital therapeutics, as I said, the video, for example, or the wearable or the pharmacogenomics is anyone who comes into the clinic, they can self-refer themselves, and we'll still be able to provide that. Patient-centeredness, that is fundamentally the central thesis to the whole center, and it's shared decision making. And efficiency, I think it needs to be evaluated. So for example, anything that we do, we have to demonstrate effectiveness. But I think when it comes to improving safety or reducing risk, I think we have definitely developed strategies to look at drug-drug interactions using pharmacogenomics and the health tracker. We've developed and tested early clinical risk alerts telling us that this person may have something to look at. And of course, looking at the risks of AI itself, we are fully aware of the bias that can occur when you're using skewed samples. And of course, the other issue is that when AI algorithms start, we need to actively make sure that the clinicians don't get de-skilled, because as soon as it spews out from a machine, it's automatically assumed it's better, it's clean, it's perfect, and actually that can be detrimental to the clinician. So we are actually actively doing that. We're making sure that that doesn't happen. And of course, the more recent things of AI hallucinations that are happening, and also in terms of where what happens is that if you go on to ChatGPT or anything and you put in something about Rett syndrome, it can create references that don't exist at all. So it just decides that there is someone in the States, and they even give you the journal name, the page numbers, everything as such. And also the other thing is AI gaslighting, which is if whatever your biases are already in the data set, the data can actually be magnified, and so you can actually have what's known as AI gaslighting, so that you actually get it worse than what you started off with. So all of those things are being taken into account to understand and see how best we can. I'm not saying we're perfect, but these are all things that we are trying to look at and make sense of it. So I want to end the talk with acknowledging all of the main issues in terms of the families in here, reverse Rett, all the professionals involved, who have been fundamental to developing this whole strategy. Thank you.